John Epstein. I'm a disease ecologist and Associate Vice President at EcoHealth Alliance in New York. I'm also a member of the International Association of Ecology and Health. I'll be moderating today's discussion. On behalf of the IAEH and EcoHealth Alliance, it's my pleasure to welcome you to today's webinar on the front lines of the Zika virus epidemic in the Americas, part of our EcoHealth webinar series. Before I introduce our speakers, I'd like to thank IDRC Canada, which has made this webinar possible through their generous support, and the International Institute for Sustainable Development for providing technical assistance. The IAEH is a member-driven scientific and scholarly society committed to fostering the health of humans, animals, and ecosystems, and to conducting research which recognizes the inextricable linkages between the health of all species and their environments. EcoHealth Alliance is a global science-based nonprofit organization located in New York City, which conducts cutting-edge research into the critical connections between human and wildlife health and delicate ecosystems to develop solutions that promote conservation and prevent pandemics, protecting wildlife and public health from the emergence of disease. Today's webinar is part of the IAEH EcoHealth webinar series. Recordings of the webinars are archived and will be made available via the IAEH website. Just a few housekeeping items. Today's presentation will be recorded, so we ask you to please keep your microphones turned off. Each of the speakers will present for about 15 minutes, and then we'll have a discussion with the speakers, including questions from you, the listeners. If you have a question, please type it into the chat window, preferably after the two presentations, and I'll read it to the speakers during our Q&A session. Remember to include the name of your organization when you type your question. Ms. Carla Zubricki will be providing technical support should you need it, and you can contact her via the chat window or on her email address, which is going to be shown on the screen. Well, Zika virus has provided yet another stark illustration of how small a planet we live on, as it's made its way from Africa to Asia and now to South, Central, and North America. It's a reminder of why we should care very much about the health and disease globally, no matter where we live. We're very fortunate today to have two very distinguished presenters who will be speaking to us about the evolving Zika virus epidemic in Brazil and preparations for its spread into the United States and specifically New York City. Now it's my distinct pleasure to introduce our first speaker. Dr. Felipe Gomes Naveca is the Deputy Director of Research at Leonidas and Maria Dean Institute, the first Fiocruz unit in Amazonia in Manaus, Brazil. Fiocruz is the leading institution for public health research in Latin America, with over 11,000 employees. It works towards the production of vaccines, drugs, reagents, and diagnostic kits, and the education and training of human resources for health services in Brazil. Dr. Naveca completed his PhD in 2006, working on the molecular basis of viral attenuation. In 2008, he joined Fiocruz and began researching the molecular epidemiology and evolution of infectious agents that circulate in the Amazon, with a focus on arboviruses. His current research includes genomic studies to characterize known and unknown viruses in human acute febrile illness, field studies on arboviral emergence in the Amazon, and virus-host interactions and evolution. He also works on the development of portable and inexpensive devices for the molecular diagnosis of infectious diseases in remote areas. In 2006, Dr. Naveca was awarded the Helio Gelli Pereira Prize of the Brazilian Society for Virology for his PhD work. Welcome, Dr. Naveca.
Hello, John. Hello to everyone. It's a pleasure to be with you today.
And Felipe, did you want to start sharing your slides, and you can begin?
Okay. So, it's a pleasure to be with you today. Can you see my slides?
Yes, we can.
Okay. So, we are talking about the Zika virus in Brazil, but we will start talking a little bit about the arbovirus. So, which are arbovirus? Arbovirus comes from the arthropod-borne virus. They are essentially zoonoses. And most of them are RNA virus, which cause fever and rash, and also some severe symptoms like encephalitis. and also death. Arbovirus emerged from sylvatic cycles between hosts, invertebrate and vertebrate hosts. And humans got infected occasionally, and when they come to a big city, it can start another epidemic. So when we have Aedes aegypti and Aedes albopictus, they are the main vectors in those cities. And we can also travel and spread it over the world. And that's what happened with Zika. So Zika virus is a flavivirus transmitted mainly by Aedes mosquitoes. It's the same as genus of the dengue virus and as well as the West Nile virus. It was discovered in Uganda in 1947, and it caused human infections reported in Africa until a few years ago we thought it was only illness. And a large outbreak called attention in the Yap Island in Micronesia in 2007. So Zika virus has its name because of the Zika forest where it was discovered during a study on yellow fever virus. So this is the paper who published this Yap Island case, the first outbreak, a well-characterized outbreak of Zika virus. So this was published in New England Medicine in 2009, and it really called the attention to this virus. So we would expect that it was not that this virus would get to America. So this is the Zika virus infectious timeline since its discovery in 1947. Then it spreads over Africa and Asia between the 60s and 80s, and got the Americas and the Easter Island in 2014. So after that, virus was detected in Brazil in the beginning of 2015 and spread over the Americas. And at the end of April 2016, we reported active transmission of this virus in 30 countries or territories in the Americas, and also in 8 in Oceania and in Cabo Verde, Africa. So the virus is spread all over the world, where in each place that you have Aedes aegypti or Aedes albopictus, it will be a place that we can find Zika. So I said that Zika virus is mainly transmitted by mosquitoes, but since 2011, there was a paper showing probable non-vector-borne transmission of Zika virus. It was a American researcher that contracted Zika in Senegal in 2008, and after that, he returned to U.S. and his wife got sick. The transmission route is most likely a sexually transmitted infection. So since 2011, we have this data, and the data are increasing. We have also other papers showing potential sexual transmission of Zika virus during the outbreak in French Polynesia, and also a new paper in the U.S. So this data is becoming important, and we can now believe that the Zika virus is not only transmitted by vectors, but can also be transmitted as a sexual in a sexual route. So, also there are a lot of cases of Zika virus infection cases that are not symptomatic. Yet we can think that it's possible to see the Zika virus transmission through fluid transfusion, and it was demonstrated during the outbreak in French Polynesia between November 2003 and February 2014. 2014. So it becomes another important issue to be aware, to look for, is to be alert of this virus transmission by blood. So Zika virus infection was associated to Guillain-Barré syndrome in French Polynesia between 2013 and 2014. In Brazil, the Ministry of Health reported an association between Zika virus infection and microcephaly. In February, WHO declared Zika infection as a public health emergency of international concern. In Brazil, in May 2015, the Brazilian Ministry of Health confirmed Zika virus circulation in the country that was previously reported by researchers at the Federal University of Bahia. In July 2015, Brazil reported detection of neurological disorders, and report in October 2015, an unusual increase in the number of microcephaly cases was observed. In November 2015, Brazil reported detection of Zika virus in the amniotic fluid of 2 pregnant women. Also, severe ocular malformation were reported. And another case of transmitted by the blood was reported in Brazil in February. So these papers were the first papers who reported autochthonous case of Zika virus infection in Brazil in the beginning of 2015. So, but what really caught our attention was the number of microcephaly associated with Zika virus infection. As you can see in this slide, we have from 2010 and 2014, the case of microcephaly does not increase yet. And in 2015, we have a huge increase in the number of microcephaly cases, especially in Pernambuco, the state in the northwestern Brazil. More than 20-fold increase in this state. So, but we cannot forget other important arbovirus that are still circulating with Zika virus in Brazil. So, dengue, we have more than 800,000 cases in Brazil until April, with an incidence rate of 600 cases per 100,000 inhabitants. Most of them, which were laboratory confirmed, are dengue serotype 1. Chikungunya, we have almost 40,000 suspected cases until now, in this year, with an incidence of 19 per 100,000 and 12 deaths. So Zika virus autochthonous transmission started in April 2015, 9 to 1,000 suspected cases until now in this year, which further were confirmed in laboratory. So we have an incidence greater than chikungunya at this time, but much lower than dengue. And we had 3 deaths confirmed associated with Zika, excluding those one related to microcephaly and other neurological disorders in pregnant women, in fetus. So this is the map of Zika incidents in Brazil. We have Zika cases reported and confirmed in all over the Brazilian states, but we have an emergency situation with high incidence rates with almost 5,000 per 100,000 inhabitants in the state. This table shows the microcephaly associated cases with Zika virus infection, and in Brazil we have more than 1,000 cases potentially associated with Zika virus infection. And other countries that reported microcephaly cases like Slovenia and US, those cases were probably infected in Brazil. So we have a very dramatic situation regarding those mothers and children that got Zika and developed microcephaly pregnancy. This paper reports some results of Zika virus outbreak in Rio. I would like to show you that the probability was the second most common clinical sign in this study, and authors report that should be added, that these symptoms should be added to case definition, while fever could be given less emphasis. So we have in our experience here in Manaus some patients that did not have fever, only macular or papular rash. This is a paper also in Rio de Janeiro with a cohort of pregnant women, and authors observed a statistical association with conjunctival injection and macular papular rash as symptoms that was statistically associated with Zika virus infection. When we talk about genetic signs of this virus in America, a paper that has just been published in Science showed that phylogenetic analysis showed that single introduction of Zika virus into America that was estimated to be occurred between May and December 2013, more than 1 year before the first case observed in Brazil. And this period was the period of the Confederation's Cup that was held in Brazil, and maybe this is which started our case in America. We observed also that the number of Zika virus reported cases increased when the number of passengers from endemic areas increased to America. Another paper published in Science by researchers of the Federal University of Rio de Janeiro showed that Zika virus infection impairs growth in human neurospheres and brain organoids that are structures of the stem cells formed by stem cells to study neurogenesis. And Zika not only reduces the growth of these organoids, but also alters morphology and halts the growth of these neurospheres. So, once we do not have a vaccine, we have to work with alternative methods to stop Zika transmission, and most of these methods are for vector control. In Brazil, we have strategies using Wolbachia and infected mosquitoes to block transmission of dengue and now Zika. And we have also mosquito that was genetically modified mosquitoes to fight this problem. But we have also a study that was conducted here in Fiocruz, Amazonia, led by Dr. Sérgio Luz and Dr. Fernando Abad Frank, that started modeling dengue vector dynamics a few years ago. So they started using a strategy of mosquito disseminated pyroproxifene in this location, and this is kind of threat that they put the pyroproxifene, and the female mosquitoes, when put these hair eggs in this trap, got the pyroproxifene and disseminated to other traps. So we found that before we found a tenfold decrease in adults emerging from the open traps after this study, and this study was also conducted in a small city because it was first conducted in a small area, and after that it was conducted in a city called Manacapuru. It's a 60,000 city, inhabitants, and in this city it was the same strategy was applied. So sentinel traps were spread over the city, and also dissemination stations, dissemination for period. And we observed decrease and also a decrease in the number of houses with positivity to Egyptite. We have 97% to 9% houses now positive, and also overthreat positivity decreased from 75% to 2.4%. So what are the challenges in laboratory diagnosis of Zika virus? Zika virus is difficult to isolate when we compare to dengue or chikungunya. We do not know how. That is, a lot of laboratories reported this. That is difficult, much more difficult to isolate Zika. Zika has also antibodies to Zika virus show also cross-reactive to other flavivirus. So in countries where you found a huge number of dengue cases, like in Brazil, you can expect a cross-reactive. For that reason, we are using reverse transcriptive polymerase chain reaction as the main method for Zika detection. Zika can also be detected in urine, and it seems to be an important sample to use, because in plasma we observed low viremia and we got positive samples until the 5th day after the rise of symptoms. In urine, we have also detected 10 days after the rise of symptoms and even more. So I would like to finish my presentation talking about other arbovirus in the Brazilian Amazon. And in the Uganda Institute, the National Laboratory of Arbovirus Research has isolated more than 200 different types of arbovirus in the Amazon. And more than 100 were new viruses to science. 36 have also been associated with disease in humans, and 8 were associated with epidemics like chikungunya, dengue, and Zika, but also Maiara or St. Louis encephalitis, Rocio, and yellow fever virus. I'd like to show you that Maiara fever is caused by Maiara virus. It's a virus very similar to chikungunya, was also reported in Manaus a few years ago. And also Oropush fever that is caused by a virus named Oropush that was Bunia virus. And Oropush virus was reported as the second most important in Brazil, with more than 500,000 cases reported in literature. But now it was overpassed by Zika and maybe also by chikungunya case. But it's a virus that is not commonly detected because it's not in the routine of the majority of the labs. So this is the data in Brazil. I'll be glad to answer any questions you have my contact.
Thank you very much, Felipe. That was a fantastic presentation. Now, as we switch over to our next speaker, and again, we'll take questions after the next presentation, and we'll have some discussion as well. But it's my distinct pleasure now to shift the perspective from Brazil, at the heart of the epidemic now, to New York City in the United States, where we're preparing for the eventual introduction and spread, really, of Zika virus. And so it's my pleasure to introduce Dr. Jay Varma, who's a physician and currently serves as the Deputy Commissioner for Disease Control at the New York City Department of Health and Mental Hygiene. He directs the Public Health Laboratory and all infectious disease control programs for New York City, including HIV, tuberculosis, sexually transmitted infections, vaccine-preventable diseases, and general communicable diseases. His division is one of the largest in the department, employing more than 1,000 staff and operating 17 clinical facilities. After graduating magna cum laude from Harvard, Dr. Varma completed medical school, internal medicine residency, and chief residency at the University of California, San Diego School of Medicine. In 2001, he joined the CDC's Epidemic Intelligence Service, working on foodborne diseases. From 2003 to 2008, he served in Bangkok, Thailand, directing CDC's TB programs and research in Southeast Asia. And from 2008 to 2011, he served in Beijing, China, directing CDC's International Emerging Infections Program, which assisted the Chinese government on infectious diseases. In 2010, he was recognized as the U.S. Public Health Service Physician Researcher of the Year, and in 2011 was awarded the Distinguished Service Medal, the highest award in U.S. public health service. It's my pleasure to welcome Dr. Jay Varma.
Thank you to everybody for joining today. I'm going to go through briefly some of the epidemiology of Zika virus as it currently exists in the United States and New York City, and then discuss the plans that we have developed here in New York City to mitigate its spread. For Zika virus in the continental United States, so that's referring to the 58 states that are currently in North America, there has been local transmission of Zika virus by mosquitoes, has not yet actually been reported. There have been laboratory-confirmed Zika virus cases identified in travelers returning from areas of local transmission since 2011. But it's anticipated with the current outbreaks in the Americas that the cases among U.S. travelers will most likely increase. And these imported cases have the possibility to result in virus introduction and also local spread in some areas of the United States. This slide shows you the distribution of Aedes aegypti in the continental United States. Aedes aegypti, as we just discussed, is the most competent vector for this virus. Now, before 2016, the map you see on the left-hand side of your screen was the map that CDC had publicly available for the estimated distribution of Aedes aegypti in the United States. With the advent of the Zika virus epidemic, CDC has reviewed data from a number of different sources and actually expanded the range of estimated Aedes aegypti in the United States. And you see that on the figure on the right. So previously in the continental United States, it was thought that Aedes aegypti was pretty much limited to the southern United States. But now CDC is estimating that its potential range of distribution is as far north as places like New York City. It is important to emphasize, at least from our perspective here in New York City, we have had extensive mosquito surveillance for over 15 years and have never detected other Aedes species, but have never actually detected aegypti. So this really just represents a potential of its distribution, not its actual distribution. The next slide here shows the current case counts in the United States as of this past week. So there have been 426 cases reported in the continental United States, all of whom were travel associated, and 36 which occurred in pregnant women. In the U.S. territories, which includes most notably Puerto Rico, there are a total of 599 cases. 3 of these are travel associated, but 596 are locally acquired, and 56 have occurred in pregnant women. So what are some of the challenges to Zika virus control in the United States? I think, probably the biggest challenge really is that there is ongoing transmission in U.S. territories, as well as in countries which have a lot of travel to and from the United States. That's including the Caribbean, Mexico, Central America, and Latin America. And this large volume of travelers has the possibility to increase both the imported number of cases, as well as create a viremic pool from which local transmission could theoretically occur. We also know that Aedes aegypti is established in southern states. And as we just discussed, it's possible that it could be distributed outside of those southern states as well. Other Aedes species may also be potential vectors. And that's an important consideration because, as I mentioned, for a place like New York City, though we don't currently have Aedes aegypti, we do have Aedes albopictus as well as other Aedes species. And it's unclear what their competency would be like as vectors. A huge challenge to the United States is the fact that in many places throughout the United States, there's a patchwork of mosquito control programs, some of which are highly functioning and some of which are not. We also know that mosquito species and virologic surveillance is limited, and that the capacity for testing infected humans is largely restricted to public health laboratories right now. Here in New York City, we have 59 cases that have been confirmed as of the end of last week, which represents 14% of the continental U.S. total. For some perspective, New York City's population is about 8 million, which only represents about 2.5% of the United States population. So our share of Zika virus cases is disproportionately large. We also have diagnosed cases in 8 pregnant women, which also represents 22% of all the cases reported in the continental U.S. And to date, all of these cases have been verified to be travel associated. Our response here at the Health Department has been focused on these areas. We're focusing on increasing the awareness of the public about how to prevent Zika virus infection and how to prevent mosquito bites. We're educating healthcare providers and assisting them with diagnosis. We're coordinating and performing laboratory testing for Zika virus. We're investigating suspected cases and confirming whether transmission is locally acquired versus imported and mosquito-borne versus sexual. We're monitoring pregnant women with Zika infection and their babies and making sure that they are coordinated with appropriate care services. And probably most notably, we're revising and adapting our mosquito control program to manage Aedes mosquitoes. This shows you some of the public information materials that we've released. There's a large advertising campaign going on right now throughout the city with the title Fight Back New York City to help educate people about how to prevent mosquito-borne viruses. We're also distributing information to, particularly in communities with large immigrant populations, about warning pregnant women about the hazards of travel to Zika epidemic areas, and that if they do choose to travel, to make sure they observe strict mosquito control precautions. We've done an enormous amount of work with our healthcare providers, issuing health alerts to all licensed physicians as well as large medical institutions. We have a number of documents available on our website. We've delivered presentations at academic medical centers. We've detected a relative under-testing in places that we would have thought to have large testing rates. So these are neighborhoods with large populations from Latin America for whom testing is relatively low compared to other areas of the city. So to respond to that, we've actually done drop-in visits at over 100 obstetric providers' offices to provide information both to the medical practice as well as to their waiting rooms about Zika virus infection. And we have a physician on call 24 hours a day, 7 days a week to respond to individual inquiries. To handle the testing and case investigations, we've actually established a dedicated call center here at the Health Department. This is actually uses and relies on the infrastructure that we originally implemented to monitor travelers from West Africa for Ebola virus. So this center is available Monday through Friday for healthcare providers to call. It assists them in completing a laboratory testing requisition form and providing detailed guidance on specimen collection and handling, since testing for Zika virus requires particular specimen collection procedures. We will then coordinate using a private courier the pickup of the specimens and ensure that the specimens are tested at our laboratory. We also have epidemiologists investing all confirmed cases, primarily to verify a travel history, and secondarily to explore for the possibility of sexual transmission. And of course, we are also conducting investigations into suspected congenital infections and Guillain-Barré cases. Of note, we have not detected any congenital infections or Guillain-Barré cases to date. This graphic is a little bit out of date, but it shows you a little bit about the extent of the response that we've had so far, which is quite substantial. We've mobilized hundreds of employees, already committed millions of dollars to expanding our mosquito control operations, as well as our human testing and public outreach efforts. And we've tested thousands of samples and handled even more thousands of provider inquiries. I want to talk very briefly before we finish this presentation about our Aedes control program, because I think this is where we've had to probably institute the most dramatic changes. Since the West Nile virus epidemic was detected in New York City in 1999, we've had a robust mosquito control program. Major components of that program include extensive community outreach, particularly regarding prevention of West Nile virus and answering concerns about mosquito control methods. We've implemented a mosquito surveillance and West Nile virus testing program among mosquitoes. We do habitat control, including responses to complaints about standing water. We do ground and aerial larvicide applications. We conduct surveillance in humans. And when necessary, we do use a truck-based, ultra-low volume adulticide treatment program in populated areas and in natural habitats. Now, and this slide shows you a little bit about to help you quantify what we did in 2015. And as you can see, we have a very active program for collecting and testing mosquitoes, for killing larvae, and as well as doing adulticiding when necessary. So one of the challenges we face is how do we adapt this program for West Nile virus for Zika? Some of the challenges relate to the vector presence and competence. So as we mentioned before, New York City does not have Aedes aegypti mosquitoes. We do have widespread populations of Aedes albopictus and other Aedes mosquitoes. And despite having hundreds of cases of annual infection due to dengue and chikungunya imported into New York City, there has been no local transmission observed in New York City. So we think that local transmission of Zika is unlikely, but it's not out of the question. So the possibility is real, but probably remote. But we also know that the public concern about Zika is far greater than it is for West Nile virus. And we worry about our ability to rapidly detect local transmission because most Zika virus infections are asymptomatic. The infectious period often passes before test results are available. And we're currently testing exclusively travelers, which limits our ability to detect anybody who might have been locally infected. We also have to consider the features of the mosquitoes themselves. The primary vector for West Nile virus in New York City is Culex mosquitoes. Aedes mosquitoes, in contrast, are day-biting mosquitoes, which suggests that we have to be worried about the daytime population consideration rather than a residential for West Nile virus. I'm referring specifically to the fact that where people go during the daytime could be potential exposure sites as opposed to primarily their homes, which is where they are at night times when Culex mosquitoes are most active. Aedes mosquitoes require different trapping protocols than Culex. They breed in smaller containers, requiring more aggressive standing water control, and their geographic distribution is somewhat different than Culex mosquitoes. This is just a slide that I won't go into in extensive detail, but does highlight kind of the different distribution. The darker areas show you on the left side where Aedes albopictus is primarily detected, and on the right side where Culex mosquitoes are primarily distributed. And as you can tell, they're not the same areas. So what have we done to adapt our mosquito control program? We are ramping up our outreach and complaint response program for controlling breeding conditions. So specifically, that means enhancing our capacity to respond to complaints from the community about standing water and then address those complaints. We're increasing the number of community meetings we held to discuss mosquito control operations, increasing our distribution of repellents to at-risk populations, specifically pregnant women. We're tracking our nuisance mosquito complaints and increasing the amount of traps that we have for mosquito surveillance. We're adapting and using new different types of traps, as well as a new arsenal of pesticides, both larvicides and adulticides. And we're using new pesticide application methods, performing ground larviciding, using truck-mounted applicators, using aerial larviciding when necessary, and using handheld ultra-low volume adulticide treatments. We've also modified our decision logic for how we apply pesticides. With West Nile virus, our decision on when to spray and where to spray has been primarily driven by either detection of mosquito pools positive for West Nile virus or the detection of human cases. With Zika virus, we're changing our approach because of our concerns about Aedes that we've discussed, and instead we're using a risk-based approach. So based on mosquito density, human behavior, and built environment characteristics, such as the presence of standing water. So we're going to be actively trying to reduce the density of mosquito populations regardless of the occurrence of Zika virus cases in humans or Zika-infected mosquitoes. And in general, we're applying a lower threshold overall for our community response than we would for West Nile virus. So the challenges that we're really facing right now is there's just a lot of uncertainty. We don't really know or have a good way of estimating how many New Yorkers are currently in risk and how many will be at risk in the future. The expansion of the epidemic into the southern U.S. states would greatly alter our response in the sense that it will increase the number of people requesting and requiring testing. And of course, we're also faced with this challenge. We don't really know how effective Aedes albopictus mosquitoes will be as a competent vector. So I'll stop right there.
Thank you very much, Dr. Varma. That was a terrific presentation as well. And at this point, it raises a lot of questions. It's clear that mosquitoes play an important role, obviously in the spread of this virus, but really in terms of control strategies. And we heard about that both in Brazil and in preparations here in New York City. So I have a couple of questions related to that for both speakers. To start with, one thing we didn't touch on in the discussion today is the idea of genetically modified mosquitoes, and there have been discussions through various scientific organizations and in the media about the development of genetically modified mosquitoes. For example, this morning in the Dallas Daily News, there was an interview with a CEO who developed mosquitoes that would breed a population of juveniles that would die, that would never make it to adulthood from mosquitoes. And so I was wondering if, Felipe and Jay, if you could give your thoughts on the public's appetite for accepting this approach, the scientific community's understanding of how effective it might be, and whether you personally think that this is something that should be part of the toolbox in terms of mosquito control. We'll start with Felipe. Just remember to unmute your microphone as you respond. Okay. Thank you.
Once we do not have vaccine to Zika, vector control measures is the only weapon that we have. So we have to use different approaches, I think. And genetically modified mosquitoes, as mosquito disseminated pyriproxine, as we are using here in Amazonas, and Wolbachia infected mosquitoes. I think that we should merge those strategies to get better results. We cannot believe that it's hard to believe that only one of them will be sufficient to stop immediately the Zika virus transmission. I believe that we should work together with using different strategies.
Okay, Jay.
Yeah, no, I think it's a critical question, and I think the challenge is always that the behavior of mosquitoes, of course, is always dependent upon the local ecology. So my perspective, of course, is geared by our current local situation, which is that we don't anticipate that there will be local transmission, though we are preparing for the worst case scenario. So it's not a discussion that we've held extensively. We've planned primarily around a strategy of using traditional vector control strategies, source reduction, larviciding, adulticiding, to address the concern about Zika virus transmission. And we are hoping and anticipating that that will be an effective strategy. Now, I think that this discussion will change, however, if we find that other Aedes mosquitoes or other strains of mosquitoes, such as Culex, for example, are in fact competent vectors. And I think that there will be a much more urgent need to address the possibility of using these. I think at a personal level, I think I'm always suspicious about changes that we can make to our environment because of unintended consequences. I think the human body is complex, but obviously our ecology is even more complex. At the same time, obviously the consequences of this infection are devastating. And one of the things that's going to be interesting to understand is whether or not this is a virus that will become endemic and cause infections at a very large scale, or will to a population similar to chikungunya, thereby naturally immunize a large percentage of the population and then settle down into a lower state of infection. And I think knowing that would help us understand whether or not we need to permanently alter the mosquito population using genetically modified mosquitoes, or whether strengthening our existing vector control would be adequate.
Okay, well, yeah, and you mentioned, the complex ecology of these virus systems, and it's interesting. When West Nile was introduced into the United States, it not only spread into people, but established itself in bird populations, quickly, establishing there were birds that were both susceptible to West Nile virus, like crows that died, and then those that were able to sustain and support infection, like American robins here in the East. So a question for both of you again is, do you expect that Zika virus will establish a sylvatic cycle? Now, this is probably a little bit more pertinent in the Amazon right now, as we've seen some evidence for non-human primates getting infected. But Felipe, do you expect, or are you looking into the possibility of a wildlife reservoir helping to support sustained infection as people are getting infected? And then Jay, perhaps less so New York City, but do you think about other animal hosts that could serve as reservoirs once the infection is making its way into people in the United States? We'll start with Felipe.
I think that we must conduct surveillance to other reservoirs. A few days ago, I read a paper from researchers at the University of São Paulo that found other animals, sylvatic animals, with Zika virus. So it's a possibility that there's a possibility that it happened. So we have to increase surveillance, as we do with sentinel monkeys to yellow fever. Maybe we could include Zika testing in these animals to get a real for a better comprehension of these sylvatic cycles.
Yeah, here in New York City, of course, because we're an urbanized environment, it hasn't been a huge concern for us, as well as because we don't know about or we haven't seen reports that local species would likely be a permanent reservoir as they are for West Nile virus. But I think, in addition to this question of this sort of theme of uncertainty, I think this is what's most challenging for us, is there is so much that we are being surprised by. I think we've been surprised at the rapidity with which this virus spread across the world, the association with severe outcomes both during pregnancy as well as in fetuses born, as well as in babies born to infected mothers, the strong and growing association with Guillain-Barré syndrome. So I think we have to be prepared for all possibilities, but it isn't something that we've been working aggressively on at this point.
Okay. Now, a question about immunology, and Felipe, you made the point that we don't yet have a vaccine for this, but do we have any evidence that either previous immunization against related viruses like Japanese encephalitis or exposure to viruses like dengue, do those provide any kind of cross-protective immunity in people?
This is a very good question, and it's something that we should work on. There is some evidence that some of those cases of neurological disorders in adults in French Polynesia had a previous infection with dengue. So perhaps we have antibodies potentializing those infections, but we have also a complex scenario. What we know about dengue is that when someone gets dengue, a person can be protected for 3 or 6 months, but after that, these antibodies enhance infection to other dengue serotypes. So we can also have something like that in Zika, but we do not know yet. We still have to. So one of the most important points, I think, that should be addressed with Zika infections.
Okay. I want to take some questions from our listeners. Here's a question from Dr. Sam Stebbins, wondering, is there something about this virus that's made it particularly toxic to fetuses, or particularly having adverse impact on fetuses as compared to other historical outbreaks we're aware of with Zika? And maybe Felipe, we'll start with you if you.
Okay. We do not know. We do not have any data regarding genetic modification of this virus that it's associated with severe symptoms. But Zika virus was discovered in 1947, and in 1952, I guess, there was a paper showing that this virus could infect the brain in a mouse model. So we have also Japanese encephalitis and West Nile virus that are well-known virus which infected the neurological CNS. So we can, with this data, we should increase the testing, genetic testing, to see if there's a genotype or a lineage that can infect it with a higher success. But we do not have this answer yet.
And Jay, do we expect to see, aside from microcephaly, which is the impact we're talking about the most in terms of fetal malformations, do we expect to see other neurological impacts or cognitive deficits in newborns that have experienced infection?
Yeah, I think what's, again, one of the big challenges, again, is trying to know what the exact range of complications will be. We already know that in women who are infected during their pregnancy, there is an increased risk of spontaneous abortion. There is an increased risk of intrauterine growth retardation, and so there are complications that would that kill the fetus essentially during pregnancy. And then among those who are born, I think there's increasing laboratory evidence that this virus is, neurotropic, that it has a predilection for neural tissue. So I think it is, I strongly suspect that microcephaly is probably just the tip of the iceberg. It's just the most severe manifestation and unique manifestation that's being recorded. But as we've seen from the case reports that have come out, the range of abnormalities is likely to be large. It's probably going to include disturbances in vision, disturbances in hearing, probably disturbances in cognitive development, and there certainly may be peripheral neural complications as well. One of the efforts that we are working with CDC on here in the United States is establishing a pregnancy registry that will help to define the range of birth defects better. I think our experience with rubella in the 1960s is a clear example of the fact that these viruses that cause congenital malformations can sweep through populations and be devastating, and that the range of abnormalities that you see at the beginning of an epidemic is really only one small part of the entire range that may actually ultimately be associated with that virus.
And given the real, I guess, possibility of cryptic infections, the majority of cases seem to be asymptomatic in adults, and we're also thinking about the risk through blood transfusions. What is the Department of Health recommending for people who might be going to Zika endemic areas, and what are we doing with blood banks in New York City?
Yeah, so our primary recommendation for travelers is split into two parts. For pregnant women, the recommendation is don't travel. And this is obviously complicated because we have a very large population that has its national origins and family members connected to Puerto Rico, to the Dominican Republic, to all over the Caribbean and Americas. But that is our primary recommendation for pregnant women. And if you do travel, regardless of whether you're pregnant or not, to use very strict mosquito precautions, long sleeves, pants, application of permethrin to clothing, application of effective insecticides to your exposed skin, and use of screens as much as possible to the extent that it's possible, or ideally even air conditioning if you can afford that. So that's the primary recommendation for travelers. In addition to that, we are also trying to caution that women of reproductive age should be on an effective form of birth control. In addition to the use of condoms, this should ideally include, a long-acting hormonal contraceptive or an intrauterine device. We just simply don't know how effective Zika virus is transmitted by sex, but it's more than we thought at the beginning. which was we didn't realize it at all. So we are strongly cautioning that women of reproductive age use a reliable and durable form of long-acting contraception in addition to condoms. And then, of course, for men who have traveled to those areas, our recommendation is for them to use condoms when they return for extended periods. And those periods vary depending on whether or not they think they had symptoms or not, but it's at a minimum of 8 weeks and up to months and the duration of pregnancy if their primary partner is a pregnant woman. Now, for blood banks, the current recommendation that's issued by the federal government, which is what we follow here in New York, is for people to what's called individually defer, which is that they are supposed to use their own best judgment to defer donating blood if they have traveled recently to a Zika endemic area. I know there has recently been approved a molecular assay to screen blood, but again, I think this is going to be an evolving situation, and I suspect that as the epidemic continues to spread, that blood banks will eventually move to a process where they're standardly testing all blood loss and potentially even asking people about exposure to reduce the risk of donating blood.
Okay. This is a question from one of our listeners, Steve Young, and probably for both of you, but we'll start with Felipe. Do you expect to see an increase in the number of Zika virus cases emanating from the Olympics in Brazil or following the Olympics and other international events? So yeah,
for at least for here in New York, we certainly are prepared. Summer is peak travel time, and regardless of whether it's the Olympics, there's the a huge soccer tournament for the entire Americas is being hosted by the United States this summer in June and July. The Copa America tournament, and those are only two events that we're aware of and planning for. But the reality is, our summer is our peak travel season, so we anticipate that regardless of the Olympics, that there will be an increase in the number of imported cases.
And Felipe, what about in Brazil? What's the conversation regarding the Olympics?
Yeah, we cannot rule out this hypothesis. Although Brazilian government is working hard to reduce the number of cases, but we have a very difficult situation at this moment. So we are large people to use repellent and other physical barriers to get protected from the mosquito bites. So also it's very difficult to say that we will not increase the number of Zika cases after the Olympics, but we are doing what we can, and we are also asking to our visitors to do that, to use repellent and to use physical barriers to get protected from the mosquito bite.
Okay. Well, Dr. Felipe Gomes-Naveca, Dr. Jay Varma, thank you so much for being with us today. These were terrific discussions, really informative presentations, and I think people really learned a lot about Zika virus from being here. So thank you. And I want to thank the audience and the listeners for joining us today. If you missed any part of this or want to re-listen to this webinar, we'll be posting a recording of it on the IAEH website and the EcoHealth Alliance website with links to that. So it will be posted online and available. So on behalf of the IAEH and EcoHealth Alliance, I want to thank everybody for today, and join us next time for webinar, which is going to be scheduled. You can find information on our website. We don't have dates yet, but please join us again for this webinar series, and have a good day or good evening. Thanks very much.
Thank you all.
Thank you.